I'll be taking the question 8 of the National College of the last 2023 November exams. Okay, my slide is not moving.
Hello, Esther.
Yeah, it stopped sharing. I'm wondering why. It's not moving, rather.
Okay.
And now,
Try and share again. Try and share again. Okay, we are seeing this slide now. Are you?
Yeah, but it's not moving, so I don't know why.
That's strange.
Dr. Esther, have you updated your Zoom? Let me.
Don't share the slide alone. Share your whole screen. It's easier.
Okay.
Your app may not be compatible with Zoom, so just share your screen.
Oh, okay. Okay, sorry about that. So the question goes this way: define neglected tropical diseases. B, give 10 examples of neglected tropical disease. What are the 5 complications of neglected tropical disease? Name any NTD in your community. How will you go about creating awareness about the NTD you mentioned? Then give examples of the WHO rapid package for treating some of the neglected tropical disease. So by definition, these are skin diseases that are acquired in the tropics and subtropic region, and usually are neglected by the global community. They are often associated with poverty, inadequate sanitation, and living in close contact with infectious vectors and domestic animals and livestock. So the examples, I group them into those that have skin manifestations and those without skin manifestations. Examples include leprosy, scabies, mycetoma, brulee ulcer, cutaneous leishmaniasis, lymphatic filariasis, onchocerciasis, tungiasis, yaws, podoconiasis, chromoblastomycosis, porotrichosis. And those without skin involvement include Chagas disease, cysticercosis, dengue fever, dracunculiasis, echinococcus, fascioliasis, the sleeping sickness, rabies, trachoma, and schistosomiasis, ascaris, hookworm, whipworm. So what are the 5 complications of the NTDs? So I group them into psychosocial and medical. Psychosocial complications include stigmatization, social withdrawal, low self-esteem, depression, and illiteracy, because children tend to drop out of school because of the complications of this disease. Medical complications will include loss of digits, like seen in leprosy, blindness from onchocerciasis, amputations from deep fungal mycosis like mycetoma, liver failure, renal failure can be seen in dengue fever, skin atrophy in onchocerciasis, hematuria, bladder CA in schistosomiasis. Name any NTD in your community, so we can name as many as we can be able to discuss: scabies, chromoblastomycosis, onchocerciasis, dengue fever. Can actually pick anyone from the list. How will you go about creating awareness about the NTD you mentioned? So I'd like to go over with advocacy. Advocacy will involve forming alliances with, most importantly, the locals in the community, using their traditional heads, their market and women leaders, people in the communities that the people can listen to, and most likely able to transmit this message in their local dialect. That can also be done via campaigns where you have these members of the community in the campaign teams to reach out to the locals in their own local languages. We can also use seminars where we train different health cadre workers on the disease condition, and also include these locals or the head of their local community, and then train them to educate the people in that community. Handbills and billboards can also be used, most importantly with cartoon in the language the people will understand, and then pass this message on these conditions and their complications as well. Give examples of the WHO rapid package for treating some of the neglected tropical diseases. So the packages are 5 in number. We have 1, large-scale preventive treatment, which focus basically on direct treatment of the mass treatment of the different conditions. So we give, for example, in onchocerciasis, we give periodic mass treatment with ivermectin. 2 has to do with safe drinking water, sanitation, and hygiene. So it's important that the communities have safe drinking water, and this will help to curb neglected tropical disease like guinea worm. Innovative and intensified disease management. So for each of the conditions here, they're talking about having using the drugs of choice to manage these conditions and then doing it effectively. Number 4 is integrated vector management. So most of these diseases have vectors that spread the infection, and it's because these people in the local communities have close proximity to them. So management of the vectors like periodic use of insecticides, most especially where the vectors are. For example, in river blindness, you go around the water bodies and then use of insecticides to take care of these vectors. 5 is veterinary public health. So like we mentioned earlier, the conditions are also transmissible from animals. So taking care, giving awareness about the implication of contracting these diseases from animals around, and then the need to give awareness about taking our livestock for veterinary checkup, and then for those that require vaccines, for example, in terms of rabies, the people that have dogs should take their dogs as at when due for the normal required doses of vaccination for those animals. This will help prevent the disease. So just a little overview. Neglected tropical diseases are a group of diseases that occur under tropical and subtropical climate conditions, and they are intimately linked to poverty. They thrive in areas where access to adequate sanitation, clean water, and healthcare is limited. It's seen in people living in proximity with animals and infective disease vectors. These NTDs affect some of the world's poorest and most marginalized communities. So NTDs were estimated to affect close to 2 billion people at the turn of the millennium, with collective daily burden that was equivalent to HIV and AIDS, tuberculosis, or malaria. So they had to do this study, take this data to prove that these conditions are actually burdensome in the subtropics, because if the burden is as much as that of HIV and AIDS, which is given so much attention, that means this condition should also have that attention as well. So the complications that are seen include condemning affected people to lifelong disability and stigma. They keep children out of school, adults out of work, and then burden households with considerable costs to seek health care. It also traps the communities in endless cycles of poverty, and also cost developing economics billions of dollars every year. So there is the WHO response, which was brought about in 2005 and it was conceived as an innovative strategy to combat these NTDs. So that was when the rapid response approach was introduced. And like we mentioned earlier, there are five grouped into five. We have the innovative and intensified disease management, large-scale preventive treatment, integrated vector management, veterinary public health, and then access to water, sanitation, and hygiene. So this is the rapid package, which I had explained earlier. So for the innovative and intensified disease management and then large-scale preventive treatment, these are medical interventions that are aimed at curing, easing, or preventing acute or chronic diseases, while the other three, integrated vector management, veterinary public health, and access to water, sanitation, and hygiene, are cross-sectional sectoral actions that are aimed at impacting on the root causes of the neglected tropical diseases. So this is the WHO NTDs are grouped into 20. The others I listed are actually a subgroup, but the main groups are 20. And currently they are 21 with the most recent addition of NOMA in December 2023. So making the list up to 21 groups or classes of diseases. I just regrouped them into different classes of etiology as bacteria, protozoa, as helminths, or viral infections, or fungi, which I had mentioned earlier. So this is these are pictures of these tropical diseases that are seen with skin manifestations. This is crusted scabies. This picture of deformities from lepromatous leprosy. This is Madura foot. I can see the deformity on the foot. We have the leopard skin and skin atrophy from oncodermatitis. This is a classic cutaneous leishmaniasis on the leg. And then this is NOMA. So roadmap to 2021-2030. This is aimed at ending the neglect to attain the sustainable development goal. The roadmap set global targets and milestones to prevent, control, and eliminate the now 21 diseases or disease groups. It also has a cross-cutting target, which is aligned with the sustainable development goals. So these targets are grouped into three fundamental pillars, and the pillars are: one, to accelerate pragmatic action that have been outlined, and then intensify cross-cutting approaches to management of these neglected tropical diseases. And the third is change operating models and culture of the people to facilitate country ownership. So thank you. That's the end of my presentation.
Thank you, Dr. Esther, for a wonderful presentation and keeping to time. So the class is open for their contribution. Tanimun, you have raised your hand, so can you make your contributions?
Thank you very much for this presentation. Can you recap your definition of neglected tropical disease?
Sorry, I was talking while I was muted. I said neglected tropical diseases are diseases that are seen or acquired in the tropics and subtropics, and neglected by the global community. They are usually associated with extreme poverty, and then living in close proximity with the vectors that spread these conditions.
Okay. So I heard that you said as skin diseases. So because the extension of neglected tropical disease goes beyond skin. So if that your definition includes as skin disease, you can just remove the skin and you will continue as diseases. Then you continue, the definition is relatively okay. and also pertaining they said give examples of who rapid package. So I think, to my view, what I understand is that the examples you give the examples, not the how the packages are in theory. If they say give example of WHO rapid package, you just give the example. That is what I understand. Like example of WHO rapid package, including rollback malaria, onchocerciasis control program, all these ones. So they need the example, what I think, not the theory of how the chronology of how to take over the rollback, how to take over the action of neglected tropical disease. But the examples, what the World Health Organization have, some of the example of its packages. Yes, so that is how I understand it. Because when they say give example of the WHO packages, you give example of what the WHO have done so far. Example of their packages that are used, that have been instituted, but not the theory of how the program is to be done. Thank you very much.
Okay, thank you, Dr. Tanimu, for your contribution. Any other contribution? Any other contributions before we go to the next? Well, let me read the messages. Most are applauding the presentation. But Dr. Ifoma is saying, is TB an example of neglected disease? Neglected tropical disease. And then Dr. Robert is saying, please, did you mention mass drug administration? And in what condition do you do it? Dr. Esther, over to you. Hello, Dr. Esther.
Okay, thank you for the questions. Okay, no, so the tuberculosis is not part of the list. Yes, I mentioned mass drug administration. I said it can be used in conditions like onchocerciasis, where we periodically treat with ivermectin.
Okay. Thank you. Is there any contributions before we go to the next? Okay, our teachers, is there any clarification or contributions?
Hello, good morning.
Yeah, good morning.
Yeah, sorry, I just wanted to just chip in something. So thank you very much, Dr. Esther. That was a very, very lucid presentation. So neglected tropical diseases, it's a topic that West Africa always sets. So either they ask it as it is, or, you know, different aspects of the conditions. So just to remind us, just as the name says, you know, these are diseases that have not really enjoyed a lot of public health awareness, and that's why they are called neglected tropical diseases, you know, and why then also they are not so high on mortality, but in terms of morbidity and devastation, that's where they are. So I just wanted to mention, because of the person who asked if tuberculosis is one of them. No. So if you read a lot of literature about neglected tropical diseases, so the entity came about because of the focus on WHO on the 3 big diseases, killer diseases, at the expense of these other diseases. And those diseases were tuberculosis, HIV, and malaria. You know, so those were the 3 big diseases that had, you know, so much WHO attention, you know, at the expense of these other neglected tropical diseases. So tuberculosis, malaria, HIV are not part of the neglected tropical diseases. Thank you.
Thank you, Ma, for a wonderful contribution, Ma. Any other contributions from our teachers? The next candidate should share his
Okay,
or her
sorry,
slide.
Dr. Atta.
Yes.
Please, I don't know if I can respond to the first person's comment. So the person I discussed with that went for the last exam, I don't know if any other person is here, actually said they wanted them to mention the classes of the rapid package. And then I think the recall had a little mix-up. Based on the person I spoke with, that the particular station, when you mention the disease condition, you now discuss the options based on that package. So I don't know for other people's
Okay.
stations. So that's why I went this way, but I don't know if other people were
Okay.
asked, like you were saying,
Dr.
control
Fatima,
for.
can you help us out here? If
Okay,
since you went
thank
to the
you.
last exam, yeah. Dr. Fatima.
All right. Yeah. Thank you very much, Dr. Esther, for the excellent presentation. These examples, actually, the way Dr. Tanimu told you, the examples of the rapid package, like the rollback malaria, leprosy package, I think you are almost saying this, your reply is reflecting what Dr. Tanimu said. You give different examples and the disease entities they are targeting. So it's the same thing you are talking. And I want to draw the attention of people going for nationals. This question doesn't look as easy as they are. The questions are held by the examiners. They are only reading them one by one for you. So you never know what next is coming up. I think it was actually an easy station maybe for the ID physicians, but not for everyone. Though we just were able to mention what we can remember, but it's not as easy as the way you presented it. So thank you very much, but it's an excellent response. I think Dr. Tanimu's points are also very valid. As you mentioned, each program, you mentioned the disease that program package is addressing. Yeah, thank you.
Okay, thank you. I'll add that to the slides. Thank you.
Okay, thank you. Thank you. Sorry. Thank you for the presentation. So, Dr. Obiamaka, you can go ahead. You have 15 minutes to make your presentation.
Thank you, sir. Please, can everybody hear me?
We can hear you.
All right, thank you very much. My name is Zubiamaka Egbe, and I'm taking the October 2023 West African Recall. I'm doing question 5. Okay, so the question goes, the above is the echocardiographic image of a teenage female patient. Question A is list the components of the triad in this condition. How do the patients present? Give 3 possible ECG changes. What factors determine clinical presentation? And then the final question is, what is the predominant arrhythmias encountered in them? So the ECG, the echocardiographic image of that teenage patient is Ebstein anomaly. And the components of the triad in Ebstein anomaly is apical displacement of the functional tricuspid valve. There's also adherence of the septal and posterior tricuspid valve leaflets to the myocardium and arterialization of the right ventricle. It has other components though, but these are the major, that's the triad in Ebstein anomaly. So the patient presents with cyanosis, fatigue and dyspnea, arrhythmias, palpitations, right-sided heart failure, and sudden cardiac death. 3 possible ECG changes, tall P waves, which suggest atrial enlargement, right atrial enlargement. And in some cases, we can also see some very giant P waves, which height is greater than 5 mm. Then we can also see right bundle branch block and supraventricular tachyarrhythmias, which may or may not exist with the Wolff-Parkinson White pattern. So the factors that determine clinical presentation include age of the patient. Infants present in typical ways, children, then young adults, teenagers, and then adults. Then there's also severity of the functional abnormalities, severity of the anatomic abnormalities, and the presence of other associated congenital heart defects, which you're also going to see as we go on. The predominant arrhythmia encountered in Ebstein anomaly is supraventricular tachycardia, and this may exist in form of Wolff-Parkinson-White pattern. You can also have atrial tachycardia, you can have atrial flutters and ventricular arrhythmias. So a recap of Ebstein anomaly, it's a rare congenital malformation of the heart involving the tricuspid valve and the right ventricle, and is characterized by apical displacement of the septal and posterior tricuspid valve, and it leads to atrialization of the right ventricle with different degrees of malformation seen in these patients. The cardinal features include what we've listed earlier on, the apical displacement of the tricuspid valve. There's also adherence of the leaflets, especially the posterior and the septal leaflets to the myocardium. Then atrialization of the right ventricle. We can also have other associated congenital defects like atrial septal defect, patent foramen ovale, ventricular septal defect, coarctation of the aorta, pulmonary atresia. They can have syndromes like Wolff-Parkinson-White syndrome, very common in these patients. They can also be seen in patients that have Down syndrome, Marfan syndrome, and Noonan syndrome. So etiology of Ebstein anomaly is uncertain, though an interplay of genetic, environmental, and maternal factors have been implicated in this etiology. So it's thought to be associated with mutations in some certain chromosome, like example, the chromosome 15q, which is thought to be involved in the embryological development of the heart in utero. Then there's also mutation in the MYH7 gene, which is frequently associated with cardiomyopathies. We can also have some maternal factors, which can include ingestion of lithium, especially in the first trimester of pregnancy, use of benzodiazepine maternal, and then also exposure to vanishing substances, these substances that they use to coat furniture. Then there's also maternal history of previous fetal loss. So these are the associated risk factors. So epidemiologically, it accounts for 0.3 to 0.6% of all congenital heart defects, though it is reported in 0.2 to 0.7 per 10,000 live births. The true prevalence is actually unknown because there could be some malforms that may go undiagnosed. So there is higher incidence of recurrence in the offsprings of women that had Ebstein anomaly as compared to the offsprings of affected men. And it's also more common in children of white females. It can present at the various stages of life. It can present at neonatal stage, infancy, adult stage. And it's more common in twins and also with in individuals with a family history of congenital heart disease. So the pathophysiology, I'll just do it's a bit ambiguous, but I'll just do a summary as much as I can. So in the normal heart, the tricuspid valve has 3 leaflets. There's the anterior, posterior, and the septal leaflets. So embryologically, these valves, this tricuspid valve is formed by, there's this process called delamination from the myocardium. So this process of delamination is just like a stripping from the ventricular myocardium to form the valves. And it continues up until the level of the AV junction, the atrioventricular junction. So in Ebstein's anomaly, this process is arrested. It can either be arrested or it's incomplete, so that delamination that happens, it doesn't get to the AV junction. So it leads to distortion of the apical, the displacement of the valves, that's the septal and inferior valves. So in Ebstein anomaly, it's usually the septal and the inferior valves that are most commonly affected. The anterior valve is also affected, but not as much. So Also, the apical portions of the valve, usually they undergo resorption, but now in Ebstein anomaly, there is complete failure of this resorption. So it now causes the right ventricle to become dilated. So this right ventricle becomes functionally a part of the right atrium, and that's what's called the arterialization of the right ventricle. So you can see that here. Can you see my pointer, please?
Yes.
Okay, thank you. So we can see that here, a significant part of the right ventricle becomes fused with the right atrium. So the right atrium, this is the right atrium, which now becomes sac-like and dilated. And the functional size of this right ventricle is now small. So we can see the valves that are affected. Now, these valves, these are the tricuspid valves. These are the septal and the posterior valves. So they are pushed downwards, as we can see here. So there's this arterialization of the right ventricle. So that's what happens in Ebstein anomaly. So as a result, there is tricuspid insufficiency or regurgitation, and this leads to severe cyanosis with dilated right atrium because of the atrialization. And then there's also right to left shunting through maybe an associated ASD or PFO. Then there's also inadequate function of the distal right ventricle because of that atrialization. There could be stagnation of blood in the right atrium. There could be functional pulmonary atresia because of this inadequate function of that right ventricle. Then there is compromised LV filling by the dilated right ventricle. So this is, we've already talked about this one. So this is also graphical illustration with all the other associated congenital heart defects like patent ductus arteriosus. We can also see the atrial septal defects, the enlarged right atrium because of the arterialization. These are the valves that have been displaced backward because of the failure of the delamination. And then you can see that the functional ventricle is now smaller in size and inadequate to carry out its functions. So history, clinical features, the patient presents with cyanosis, fatigue, like we've talked about before, and palpitation, sudden cardiac death. And then these clinical features, the patients, it varies depending on the age, and then also the anatomical structure and conduction system abnormalities that we see with their resultant hemodynamic effects. So these are because this is adult medicine, I didn't talk about the presentation in pediatrics patient, but these are the features that are seen in teenagers, like the question that was asked, and then adults. So on examination, we can see all these ones: clubbing, hyperdynamic, precordium. Then there is usually a left parasternal prominence, which could lead to precordial asymmetry. Then split first, second heart sound. There's also third and fourth heart sound. And then the holosystolic murmur of tricuspid regurgitation. Investigations for this patient for diagnosis include echocardiogram and is the diagnosis test of choice. Is the imaging study of choice to evaluate Ebstein anomaly. So it's you could evaluate the tricuspid valve leaflets and also the size and function of the different cardiac chambers. So these are the features that we can see on echo. There is an apical displacement of the septal leaflets of greater than 8 mm per meter squared, and this is the principal feature of EA. And there's also abnormalities in the morphology and septal attachments of the leaflets. There is the dilated right atrium. We see arterialization of the right ventricles, and then different structural heart abnormalities. Then we can also see feasibility of valve repair. If the patient is going to benefit from repair of the valves, you can also see it on echo. So this is an example of a 4-chamber echo view of a patient with severe Ebstein anomaly. So we can see the displaced, you can see the displaced septal leaflet, and then the anterior leaflet is immobile. The functional right ventricle is also very small because of that atrialization. It has been fused with the right atrium. And so we can also, that's what we can see here. ECG findings would, on ECG, we are going to see a right bundle branch block. You're also going to see tall P waves, which are suggestive of right atrial enlargement. Then there's prolonged PR interval. There could be first degree AV block. Then we can also see delta waves due to pre-excitation from accessory pathways, which are also common. Then we see supraventricular tachyarrhythmias, most commonly the AV reentrant tachycardia. Then we can also see atrial flutters, ventricular tachycardia. So if there is supraventricular tachyarrhythmias presenting in form of Wolff-Parkinson-White, we are going to see a short PR interval, all those typical features of Wolff-Parkinson-White. So this is the ECG of a patient with severe Ebstein anomaly. So there's a prolonged PR interval. There's prolonged PR interval is greater than 220. Then there's also right bundle branch block. And then we can see the Bizet configuration of the QRS complex. Then this is also the typical classic presentation of a Wolff-Parkinson-White, where there is short PR interval. Then there's also delta wave, which is the upslurring of the QRS complex. That's it. Then so these are the things we see if the patient presents with Wolff-Parkinson-White syndrome. So the next investigation is chest X-ray. Chest X-ray in these patients may be normal. You can also find cardiomegaly. There may be decreased pulmonary vasculature, the large right atrium. Then a cardiothoracic ratio, once it's greater than 0.65, it's a poor prognostic factor. We can also do a cardiac MRI, which may be used to assess ventricular size and function when the echo quality is image quality of the echo is inadequate. Then cardiac catheterization is rarely performed, but it can, in centers where it's done, it can confirm echocardiographic findings. Cardiac CT scan, cardiac complex tomography might also be done to assess right ventricular ejection fraction and the anatomy of the valves. So treatment of Ebstein anomaly is complex and is dictated mainly by the severity of the disease, and then also the presence and the effect of accompanying congenital structures and the electrical abnormalities. And the treatment options include the medical therapy, the radiofrequency ablation, and the surgical therapy. So for medical therapy, we do antibiotics prophylaxis for infective endocarditis because of the risk factor for IE on account of the damaged valves. Then we can also do pharmacotherapy for heart failure, secondary heart failure, using ACE inhibitors, diuretics, and digoxin. You can also use antiarrhythmic agents for the different arrhythmias. And then diet and activity, a low sodium diet is usually recommended on account of for symptomatic relief from fluid overload. And then the activity for the patient can be allowed as he or she tolerates. So the radiofrequency ablation is a curative therapy of supraventricular tachycardia and is currently the treatment of choice. So surgery, correction of the principles of the surgery include of surgical therapy include correction of the underlying valve abnormalities, correction of any associated intracardiac defects. It can also be used as a palliative procedure in early days of life as a bridge to more definitive surgery later on in life. And is also the surgical treatment of the definitive treatment for associated arrhythmias, apart from the radiofrequency ablation. So these are the indications for surgery: worsening heart failure symptoms, evidence of paradoxical emboli, arrhythmias that are refractory to medical therapy and to radiofrequency ablation. Then if there is significant cyanosis, which with percentage of oxygen saturation of less than 80, and or polycythemia of 16 gram per DL or more, then if the tricuspid regurgitation is really severe, is an indication for surgery. So these are the different surgical modalities that can be used. There is the Da Silva cone reconstruction, which from the literatures I've looked at, it seemed to be the preferred surgical option in young children and adults. Then there's also the Danielson repair. There's the modified Danielson repair, the Carpentier monocuspid repair, and tricuspid valve replacement. So complications of Ebstein anomaly include heart failure, also intractable atrial.
Can you round up?
Yes, I'm rounding off now. Or atrioventricular arrhythmia. There can also be sudden cardiac death due to ventricular arrhythmia. So these are some of the differential diagnoses: congenital tricuspid atresia, Hall's anomaly, aberrant tendinous tricuspid valve cut with tetraene of the leaflet. So these are my references. Thank you for listening.
Thank you, Dr. Obiomaka, for the wonderful presentation. So the class is open for contributions, questions, comments before we go into the messages. Anybody, you can raise your hands electronically. Okay, while we're waiting for anybody, let me read some of the chats. So in addition, Dr. Sawa said, in addition, one of the key ECG features is fragmented QRS complex. Dr. Akinwumi said very tall P waves greater than 6 millimeter, called Himalayan P waves, can also be seen on the ECG. So those are the two. Then Dr. Success is applauding your presentation. Then Dr. Rukaya said atrial fibrillation is also common. You don't seem to have mentioned it. Any other contributions? Okay, over to our teachers. If I don't know, Dr. Kopi, are you in the class?
Hello, Dr. Atta. 2 hands are up. Kopi is
Okay,
not in class.
I'm not seeing. Okay, I'm not seeing them there.
Fatima,
Okay, you can go ahead. You can go ahead. You can go ahead, please. Yes, just.
Yeah. Thank you very much, Dr. Obiamaka, for that excellent presentation. The question, I think the last option from the question said, what is the predominant arrhythmia in this patient? So you should mention the predominant arrhythmia in this patient. Which one is it?
Okay, Ma, thank you. Thank you so much for the questions and the comments. Okay, so the question was, what is the predominant arrhythmias? So because arrhythmias was mentioned in the question, that's why I assumed they wanted more than one. So that's why I said SVT. But the most, if it's just one that is being asked for, is SVT with Wolff-Parkinson-White pattern. That's the most predominant arrhythmia.
All right, yeah, it's correct. Wolff-Parkinson-White syndrome is the commonest arrhythmia that lead to death in them.
Yes,
Okay.
Ma. Then thank you for the comments in the chat box. I think I mentioned that Himalayan P waves somewhere. P waves that are greater than, I think it was mentioned somewhere. Okay, yes. Himalayan P waves that are greater than 5. And then thank you for the other comments. I think I also mentioned atrial fibrillation somewhere, I mean in the overview, atrial fibrillation as one of the common ECG findings too. Thank you so much.
Hello.
Dr. Adeyanju, you
Hello?
can.
Yes. Thank you very much. Good morning to our consultants and everybody on the platform. Thank you very much for your presentation. I just want to add one or two things. as you rightly said, Epstein anomaly is very, very rare. But it's being rare might be because we're not doing enough echoes to get these people. It's commoner in white women, like you said, but we are seeing it in our environment now. But I just want to add one or two things that I did not have. That's the prognosis. Prognosis is bad if they present early, and then in male patients, they have poorer prognosis. Also, independent of many comorbidities or other congenital heart diseases, they have a poor prognosis. And as we rightly said, with Parkinson-White or pre-excitation, or pre-excitation is the commonest thing that even make them to present to the hospital even before heart failure at times, especially when they are old, maybe in the young age group between 30 to 35 or 40. Thank you very much for your presentation.
Yeah, thank you, Dr. Adeyanju, for your contribution.
Thank you so much, Ma, for those excellent contributions.
Okay, any other contribution before our teachers come in? Okay, over to our teachers.
Hello, Dr. Atta.
Yes, ma'am. Yes, ma'am.
I don't know if our Chief Chitu, Chief Emigu have any comments before I make my comment. Chief Chitu, sir. Chief Emigu, sir.
Please go ahead, Dr. Christopher.
Go ahead, Dr. Christopher.
Okay,
No
sir.
comment.
Okay, sir. Thank you, sir. The presenters today, you just ignore the background noise. The presenters today did wonderfully, both ladies, wonderful presentations. Wonderful. Thank you so much. Showed you did your research. And I really want to appreciate this class for the active participation, the questions, the comments. Please keep the comments coming. It's not easy. Most people answer this question. It's not their subspecialty, which is part of the training in this class. We want people that are not that subspecialty to answer these questions so that they will benefit. Keep giving your subspecialty and we are helping you. So it shows that it's so well that you that subspecialty. Most appreciate because thank you so much. Thank you. Then I want to
Hope I can still be heard. Dr. Atta.
We can hear you now.
Okay.
At some point, you went off. Yeah.
Yes, so I want to appreciate our teachers, Chief Cookie. Thank you, Ma. Consistency is really amazing. Thank you so much, Ma. Dr. Remigo, Dr. Titu, Dr. Bansi, Dr. Manza. I cited Dr. Chinedu, Dr. Fatima, Dr. Kopi in absence, and our dear class. Thank you so much, Dr. Yusuf. Thank you so much, sir. Thank you. And all our consultants. I don't know if I saw the names, but those I cited, I want to appreciate you. Thank you for coming to class. And then one more thing is that